السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. إن شاء الله اليوم هنخش في المواضيع اللي هي المهمة طبعا في الترانسبلانت. كل اللي كان فات ده كله مجرد مقدمة عموما عن الميديكيشن والترانسبلانت والبينيفيت والريسك والكلام ده كله، وازاي تعمل بريبريشن. طبعا لسه ما خلصناش البريبريشن للريسيبيانت والليفنج دونر والكلام ده كله هنتكلم عنه بالتفصيل. بس انا حبيت اليوم يعني كان معانا حالتين ريجكشن، فالمهم حبيت نتكلم عن موضوع الريجكشن اليوم. ازاي تتعامل مع الاكيوت جراف ديسفانكشن بوست ترانسبلانت، من الموضوعات الحيويه ومن الموضوعات الثقيله ومن الموضوعات المهمه. ودي من اخطر الموضوعات هتكلموا عنها. هنحاول نغطي لكم الثلاث مواضيع دول بسرعه. الريجكشن عموما عندنا الاكيوت ميديتد انتي بودي ميديتد ريجكشن، وعندنا التي سيل ميديتد ريجكشن، وعندنا الميكسد. هنحاول نخلص الثلاث مواضيع دول، وبعد كده نخش على الحاجات اللي هي بتقابلنا دايما في العيادات الترانسبلانت: البي كي فيروس والسي ام في والاي بي في. هنغطيهم مع بعض الثلاثه دول، وخاصة البي كي فيروس ازاي تتعامل معاه، والسي ام في. طبعا احنا اتكلمنا عن الموضوع ده قبل كده بالتفصيل الممل في محاضرات سابقة زمانا، من زمن يعني من سنتين ولا حاجة. بس ان شاء الله نحاول نديكم التريكات. كل الغرض من الفيديوهات القادمة عموما ازاي تتعامل مع الحالات، ازاي تبقى راجل بتاع عيادة، بتاع سوق، بتاع بيزنس، بتاع شغل وكده. ازاي تخدم المريض عندك في العيادة، او المريض اللي هو عنده اكيوت بروبلم دلوقتي، وانت اللي دلوقتي لازم تاخد ديسيجن في العيان. فهنديك البروتوكولات والجايد لاينز اللي هم ماشيين بيها هنا، والله المستعان. ودايما لا تنسوا الصلاه والسلام على حبيبنا محمد، ونتوكل على الله. هنتكلم اليوم على اكيوت جراف ديسفانكشن مانجمنت بوست كيدني ترانسبلانت. ايه هو الايم عموما بتاع الترانسبلانت بتاعك؟ ان انت تدي العيان ده ياخد كدني واحده على ما يعني تغطيه على قد ما يقدر. يعني انت طبعا احنا زي ما قلنا السرفايفل بتاع الجرافت عموما في الليفنج above يعني 90% in 1 years and 95% above 95% in 1 years and above 90 for 5 years. عموما قلنا من حوالي من 18 ل 20 سنة، بس شفنا حالات 40 سنه و50 سنه والجراب شغال كويس. فانت الايم دايما ان انت تحافظ ان هو ياخد one kidney for his life without any biopsy, and this kidney working without any problem, without any acute dysfunction, and optimal immunosuppression to make balance between the side effects. As we mentioned in immunosuppression, a lot of talks already done about the risk of rejection and the risk of infection malignancy after transplant. Early post transplant, this is the most important slide. I need you to put this in your clinic as a screenshot. خليها جنبك في العياده. Any delayed graft function. دايما الديليد جراft فانكشن انت دايما بتشيك. اهم حاجه عندك في الديليد جراft فانكشن بعد الترانسبلانت الهايبركاليميا، البوتاسيوم العالي، والساينز اوف ريكفري. هل في يورين اوتبوت، هل في امبروفمنت ان كرياتينين اور لايتس اور نو، وامتى توقف الدياليسيس، وامتى تبدا دياليسيس للعيان بعد اللي هو ويز ديليد جراft فانكشن. لان في مرضى ساعات اللي هم خاصه مع الديسيز دي كيدني اللي هم افتر كارديك ديس بياخدوا لونج تايم، وممكن في ليفنج كيدني حصل لهم لونج اسكيميا تايم during surgery because multiple vessels or surgical problem, whatever, just warm ischemia time prolonged during the surgery and the patient need dialysis. This is a marker of an indication for dialysis, the most important marker, hyperkalemia, because this will kill your patient. And the second issue is that patient not making urine and it's worsening kidney function, daily urea increasing with uremic symptoms start to be appear. This is another indication for dialysis. Urine flow and wound care, prostate, and obesity. Put in your mind if your patient PBH, as I told you before, maybe need longer days of folic acid. May also maybe will need tamsulosin for his prostate PPH. And obesity also, the risk of complication with obesity, wound healing, dehiscence infection, and also delayed graft function. Ambulation should be early post-transplant, post-operative day 0, day 1, as patient tolerated. Nutrition, just keep your patient around his target weight, because sometimes the patient you're giving fluid, and the patient reach around 10 kilo above his target weight, and it all load in the heart. The patient will go to heart failure and more hospitalization, more cardiac side effect. And serum albumin as the marker for nutrition. Underline the end stage renal disease diet. Just keep this patient in renal diet until he will be recovered. After that, you should remove this restriction for the patient, especially if start to be hypokalemic, hypophosphatemic, hypomagnesiemic. Atelectasis and respiratory tract infection, you should enhance or encourage your patient for using incentive spirometry after transplant. Urinary tract infection is all the culture reports stent. Most of the patient, because folic acid and stent develop urine tract infection during the postoperative day 2, 3, 4, whatever, or after removing the folic acid by day 5, they feeling burning urine and persistence, leukocytosis, patient some fever, spikes of fever. 37 means fever in transplant patient, means 38. Don't forget this one. And 38 means 39 or 40 degree for post-transplant under immunosuppression. Acute rejection also, just for this creatinine start to be decreasing, and then suddenly decrease urine output, creatinine start increasing, and you should send the DSA and do ultrasound and do just biopsy if all this came negative. Therapeutic drug monitoring, see nice sirolimus and mycophenolate as needed. Proteinuria, urine depth, ACR for recurrent gene, and we'll come to this marker for follow-up. Clinic visit and blood work scheduled. Already we mentioned this in last talk by the last two slides, how to arrange. I need you to keep this also on your clinic, on your hospital. Just for 0 to 1 month, weekly clinic visit, or twice blood work, twice weekly blood work, and you can decrease with the time. As you can see, you can take a screenshot and you can put in your clinic or in your hospital to program the clinic visit and the blood work after kidney transplant. Outcome for kidney transplantation. We mentioned before, most common cause of death with functioning graft, cardiovascular, and the most common cause of graft loss, death with functioning graft. Death with functioning graft, cardiovascular, and the most common cause of graft loss, death with functioning graft, followed by chronic rejection. So I need to start this rejection now to be sure we are under close monitoring for our patient rejection. And this diagram explained before. Acute graft dysfunction now. Just keep this also in your clinic, on your hospital, in your transplant unit. When we have any patient with acute graft dysfunction, you need just, if you serum creatinine, for example, coming down 100 and suddenly 200, you should repeat first. Consider reconfirming, just repeat the serum creatinine and repeat lice and whatever. And send with this also serum CRP and C9 level or whatever. And you should examine your patient volume assessment if you need behind the pre-renal or no. And we'll come to this differential diagnosis. If it's confirmed your creatinine is high with high CRP, you have two parameters now, either acute infection or this we are using this, we are doing this with routine blood work for all our patient post-transplant. I know it's a little bit expensive, but if you have resources to do this, to just to monitor these two parameters, they can give you guidance for this infection or just rejection, and maybe both, but mainly infection will come with leukocytosis and other picture of infection. And if your CRP is normal, just go ahead and the volume assessment and C9, be sure your C9 level within the target according to your center protocol, as we discussed in C9 before. History and physical examination. Also, you can do a septic screening, urine blood cultures, ultrasound, Doppler ultrasound for your graft. You should send urine ACR, especially for you suspect recurrence of GN. And natro pro PNB and natropeptide for just signs of congestive heart failure or heart failure. And this will affect your cardiac output and decrease the graft perfusion. And consider biopsy of all this out of the diagnosis. A complicated post-transplant course, you send serum creatinine is rising already, and you send CRP, tacrolimus level, ACR. This is the four parameter, just put in your mind on your clinic to follow. The blue one is the serum creatinine. We have spikes here of serum creatinine. We'll come to clarify here. This serum creatinine increased here, and this one is tacrolimus level, and this one is ACR, and the red one is CRP. If you have this CRP is high and the creatinine is high, but tacrolimus level not high, and the ACR not high, this means you have either with CRP high and creatinine high, acute rejection, UTI, or other infection. This is a differential diagnosis in this part. If you have CRP and the creatinine high without tacrolimus level is not the cause of this rising kidney function. Volume depletion and high C9. If you have high creatinine and high tacrolimus level, you should maybe just one either volume plus C9 high dose vasoconstriction. Put this marker here and this side here, just only high creatinine and all parameter is okay. Just put in your mind just PK virus nephropathy. And also chronic allograft nephropathy recurrent gene if you have high ACR here with rising creatinine. ACR is rising with rising creatinine, either with chronic transplanticular nephropathy or recurrent GN. This is the most important diagram. Just keep in your clinic also and keep this for parameter with you for any acute graft dysfunction in your clinic post kidney transplant. This again, the causes outcome of kidney transplant, what is the most common cause of death with function graft, and what is the most common cause of graft loss. You can read it, and this potential immunological and non-immunological causes of allograft dysfunction. You can read this already. And now, what is your differential diagnosis when any patient came by acute graft dysfunction? Just keep this in your mind forever for any patient with AKI, pre-renal. I presented a long time ago acute kidney injury in details, a long lecture. I know you can hear it and you can just, you'll enjoy it because I covered everything I talk in Toronto for this talk about AKI. We have pre-renal AKI, intrinsic AKI, and post-renal AKI. Usually in AKI, you should just look out for any cause from this can cause pre-renal AKI. You should rule all this and you should do the workup if any sepsis you suspected or whatever. And any drugs you can stop, you can stop. Any volume, diarrhea, vomiting, diarrhea, diuretic, whatever, you can stop and release IV fluid just to be sure you cover the pre-renal part. Post-renal part is easy to be covered by just by ultrasound or CT abdomen without contrast to rule out post-renal obstruction or any cause from post-renal. If these two causes you try to look and to correct and no benefit, you should look for intrinsic causes. And this the most important is acute tubular injury or tubular intestinal glomerulonephritis, myeloma, lupus, vasculitis, recurrent GN, whatever, or rejection or TMA or whatever. Just all this can be from other blood work parameter can guide you from the history from just finally this only can be diagnosed also by biopsy. You should proceed for biopsy if these two ruled out. Differential diagnosis for any acute graft dysfunction post-transplant. Put in your mind first thing is rejection. So my aim today just concentrate for this lecture and second lecture and third lecture about rejection. Maybe I will cover another talk about rejection to cover both. Today we'll cover antibody-mediated rejection and maybe next video we'll cover T-cell mediated rejection with mixed rejection. And after that we'll cover PK virus CMV. This is the most important in your daily practice post-transplant. Adherence issue, just another differential diagnosis if your patient taking medication or no, and recurrent or de novo primary GN or C9 toxicity ruled out by serum, tacrolimus or cyclosporin, whatever you are using. TMA from CBC you can diagnose and hemolytic workup and you can go by biopsy and acute tubular necrosis ruled out. If you have urine sample and you can look under microscope, it will be easy to see heme granular cast, but this will not rule out the GN also. But the final definitive diagnosis for all this just should be kidney allograft biopsy. Acute rejection. What is this? What your understanding about rejection? Antibody-mediated allograft rejection is a significant and often severe form of allograft rejection that is unresponsive to treatment with standard immunosuppression medication, considered to be major cause of renal allograft loss. A form of allograft rejection triggered by production either patient have antibody or de novo antibody directed against the non-self donor HLA antigen. Allograft damage occurs as a consequence of antibody binding to endothelial cell foreign antigen, and we'll come to explain this by diagram. Antibody-mediated rejection also has occurred with all immunosuppression regime, even if you are using ATG or thymoglobulin depleting therapy. Today, it's believed that the majority of cases of late allograft dysfunction and loss are caused by presence of DCA to HLA, decent donor-specific antibody to HLA antigen. Antibody-mediated rejection, first, the antibodies occurs, which is followed by detection of C4D in the biopsy sample. and then tissue damage started to be detected, and finally graft dysfunction occurs. The target structure for immune attack are endothelial cells of the kidney, tubules, or kidney cells. Evolution of the antibody-mediated rejection started after transplant here with preformed or de novo DSA, and this will start making subclinical rejection by endothelial damage, and after that will appear by acute allograft dysfunction and acute clinical ABMR, and then chronic ABMR, and will end by graft loss. And with the old diagram already every one of us know for de novo DNA post-transplant, and they start by either just de novo and new antibodies, either from under immunosuppression, non-adherence, or whatever. And this peritubular capillaritis just will end by subclinical injury, and after that it will be appeared with rising creatinine, decreased urine output, worsening kidney function with clinical dysfunction, acute dysfunction, and after that will end by chronic EFTA, transplant glomerulopathy, and will end by graft loss. Again here, subclinical, preclinical, acute, clinical, and chronic rejection. This is a cascade of allograft dysfunction secondary to either de novo or preformed donor-specific antibodies. And this diagram just to show you the importance of our talk today. What I'm aiming just is the cause. The most common cause of graft loss is antibody-mediated rejection, but 64% already either ABMR or probable ABMR or mixed rejection. So this talk and next talk will concentrate on the rejection, and around 53% from non-adherence, and non-adherence around 47% from this antibody-mediated rejection. Just also GN around 18%, followed by this one. But just all this diagram just show what is the most common cause. Also by BK virus here, and medication or surgical condition here, and just look here. All this covers. Look here. All this area covers the rejection. So the most important talk in kidney transplant should be about rejection. So I prefer just to go ahead for this topic, and after that we'll continue our topic as our time and our availability. Here also, as we can see, post-transplant, this antibody-mediated rejection is not because patient under heavy immunosuppression here. It will appear late days after transplant here. After 100 days, it start to be appeared. Antibody-mediated rejection as a cause of graft loss, followed by glomerulonephritis, followed by EFTA, also chronic allograft dysfunction. This is the most common causes here, but as you can see, no major abnormalities here is the highest causes of graft loss. This included a lot, either cardiovascular, hemodynamic, surgery, or whatever. But with the time, with late, it will appear this antibody-mediated rejection is a major cause of graft loss. What is the mechanism of antibody-mediated rejection? Complement-mediated inflammatory response, neutrophil, macrophage, other inflammatory cells. Either complement-mediated, complement-independent, direct damage by donor-specific antibodies, and we'll come to this by diagram. Renal transplant rejection, as we can see, started by immune response. We have antibodies in our recipient blood, and this will attach to HLA antigen here in the endothelial surface of our tubular cell, and this will activate complements. We'll call complements that complex here antigen antibody complement complex mediated inflammatory cascade, and this complement activation in the cellular injury that will end by cellular or humoral vascular antibody-mediated rejection and loss of your graft. And this is a molecular cellular, but this is another diagram just shows this, and this is endothelial cells of our tubular cell. HLA antigen here, and this antibodies attached here, and this is called complement cascade, will end by damage and tubular injury, and this will end by antibody-mediated rejection and inflammation and antibody-mediated rejection, the cascade from all this cellular pathway. Again, this is another diagram just shows this cell death and damage after this complement activation from antibody with HLA antigen on the endothelial surface. And this C4D is like the fingerprint or footprint of this inflammatory cascade. It will appear in our histopathology by immunofluorescence or immunohistochemistry. Acute allograft rejection is defined as acute deterioration in allograft function associated with specific pathology changes in allograft. We have two types: acute T-cell mediated rejection. This characterized by lymphocytes infiltration of the tubules, interstitium, and in some cases an arterial intimacy. ATCL mediated caused by T cell react to the donor histocompatibility antigen present with the tubules, interstitium, vessels, glomeruli of the allograft. However, another inflammatory cells also may contribute to this inflammation. Mainly lymphocytes infiltrate this acute T cell mediated rejection, acute antibody mediated rejection. This diagnosis established by morphological evidence of acute tissue injury, evidence of circulating donor-specific antibodies, and evidence of antibody endothelial interaction like footprint or C4D deposition in the allograft. Diagnosed ABMR can be made without DC or C4D. Just keep this in your mind. Subclinical rejection divided by present histological evidence. Some centers do just protocol biopsy, and they saw the evidence of acute rejection on biopsy without an elevation of serum creatinine. Most are TCR, T-cell mediated rejection. And this BAMF 2013, and we have now 2019 and 21. This criteria for diagnosis are old. The older classifications, they depend on the donor-specific antibodies and this C4D, evidence of C4D already, the complement activation, and evidence of tissue injury, capillaritis, glomerulitis, vasculitis, TME, and DTN. These all the criteria for ABMR. As we mentioned, biopsy, we can see this tissue injury, clinical renal impairment, microvascular inflammation, C4D, and do we see all this criteria? And we came here to BAMF 19 also. Histological evidence of acute tissue injury include one of the following: either microvascular inflammation in absence of glomerulonephritis, intimal or transmural arthritis, acute thrombotic microangiopathy, acute tubular injury, evidence of antibody production, linear C4D staining, and donor-specific antibody in the serum. Usually, we are sending this safe or any allograft dysfunction. And this BAMF, you can read this, and we have updated, I think, 21 now. And this criteria for active ABMR and with C4D staining without evidence of rejection, another chronic active ABMR and chronic inactive ABMR. And I'm trying to just make it clear here, just keep it in your mind. Histological evidence, three criteria for ABMR. Histological evidence, as we mentioned, microvascular inflammation, intimal transmural arthritis, acute thrombotic microangiopathy, acute tubular injury. Evidence of current or recent antibody, antibody or vascular inflammation, like linear C4D staining in the peritubular, at least moderate microvascular inflammation, increased expression of gene transcription, but we need just C4D and deposition in the peritubular capillaries. Also, serological evidence of donor-specific antibodies, and this criteria for chronic antibody-mediated rejection, will come to this later, and C4D without evidence of rejection, and chronic antibody-mediated rejection will come to this also. Just for histopathology, this is normal glomeruli, as we can see, is parietal cells and open capillary loops here, with endothelial and mesangium here with mesangial cells. It looks like this is normal glomeruli. And this glomeruli with glomerulitis or glomerulonephritis, the cell here, capillary lumen or capillary loops filled with inflammatory cells here. As you can see, this is a picture of glomerulonephritis or proliferative glomerulonephritis. Also same here, glomerular capillary is filled with inflammatory cells. And this is a picture of peritubular capillaritis. This is the tubules, and this peritubular area. And this peritubular with inflammatory cells, and this also is inflammatory cells, as you can see. This one also peritubular capillaritis. And arthritis, as we can see in the intima here, I can see inflammatory cells. This is a dark blue or dark dots. This is lymphocytes fills the intima of the vascular. This endoarthritis, and this by immunofluorescence, immunohistochemistry, C4D deposition, as you can see. And this another by immunofluorescence showing C4D staining is the peritubular capillaries already for BMR. And just to remind you, C4D positive acute and C4D negative. And what is the cause of C4D negative ABMR? Sometimes you can see by immunofluorescence or immunohistochemistry. Either this patient under treatment or sample not covers this area or antibody mediated but complement independent injury or remnant of previous active ABMR. يعني just maybe this remote delayed biopsy or after treatment, or maybe this cascade already complement independent injury. C4D is still very useful marker for antibody-mediated rejection. ABMR maybe occurs with absence of peritubular C4D staining and may be difficult to identify. Correlation with this is helpful, but both C4D and the DSA titer are not stable and can increase and vanish. Therefore, at any time, at any given time, this factor may or may not be demonstrated or can be measured, even if ABMR is or has been present. Take care. Maybe we can diagnose now ABMR without C4D or DSA. Chronic lesions, evidence of chronicity already, as you can see, transplant coronaropathy, peritubular capillary basement membrane, multilayering, arterial intimal fibrosis with new onset without other cause. Ideally, evidence of donor-specific antibody can be seen. Transplant coronaropathy, peritubular multilayering, as we mentioned, absence C4D and active lesions. Ideally, a prior documented diagnosis of active or chronic active antibody-mediated rejection. The picture of chronicity, as you can see, EFTA, tubular atrophy, and interstitial inflammation, glomerular membrane doubling here and contouring, and we'll come to another one, arterial hyalinosis and arteriolosclerosis, as you can see. The picture already, you can see this glomeruli with multi-layering and this silver stains already. You can see also multi-layering here and the thickening of the glomerular basement membrane and his tubular atrophy, interstitial inflammation, fibrosis. Also, this diagnosis like tubular atrophy, interstitial inflammation, and multi-layering, a lot of here silver staining, and the tubular here multi-layering, tubular basement membrane. Transplant glomerulopathy, as we can see, also tubular multilayering. This is multiple slide already. This is normal electron microscopy, but this one shows endothelial swelling and vacuolization with the electron lucent widening here of the glomerular basement membrane, and you can see some layering here, some layering. This is for chronic antibody-mediated rejection. And this early changes here, you should choose this a little bit thickening, and after here you can see multi-layering in this glomerular basement membrane. Again, also this thickening and multi-layering of the peritubular capillaries with basement membrane multi-layering, as you can see multiple layer here also and multiple layer here. Complexity of the diagnosis, compatible pathology in the absence of C4D, documented is well documented and may still be compatible with ABMR even in absence of C4D or DSA. Sometimes maybe were not present, but other finding was compatible with ABMR. The best option is prevention for approach for any patient with ABMR. Treatment often less ideal and no large good studies already for that. We'll come to prevention of antibody-mediated rejection, prevention of de novo DSA with good matching, adequate immunosuppression, adherence to the medication, and prevention of ABMR in those with preformed DSA, just with close monitoring. And this patient on cyclosporin, patient on tacrolimus, this just revealed the patient with tacrolimus was associated with lower prevalence of de novo DSNA more than cyclosporin. So the tacrolimus is intense or aggressive immunosuppression in comparison by cyclosporin. Just to put in your mind, if your patient with recurrent BK or difficult BK virus to control, just transfer him from tacrolimus to cyclosporin because less intense immunosuppression with cyclosporin in comparison by tacrolimus, and usually cyclosporin also interfere with MMF absorption, will give you mycophenolate low level. But just keep in your mind to keep your target above 6 as you can. If you will keep your target above 6, it will decrease the risk for de novo DSNA. Just don't go below 5, but better to keep above 6 for all patients, either acute or chronic, as we mentioned our immunosuppression talk before. Matching, better matching, especially with DHLA, either AB and DRDQ. You can see here According to the number of matching, it will give you the either DQ de novo. They say very survival is better with zero mismatch. But once you increase the mismatch, it will give you a high risk for de novo DNA if you have a lot of mismatch or a high epitope mismatch. What are the treatment option now? Just for treatment ABMR, this is the most important what I need from this talk to confirm how to treat the patient now. You know how to diagnose now. What is the main key point in treatment? Just confirm diagnosis by kidney biopsy. You should do kidney biopsy and donor specific antibody from day zero. As you can, according to the facility, and weight benefits versus risk, aggressive therapy, and toxicity, and the cost of all immunosuppression, and no clear evidence because we can't do randomized control trial for all these patients with rejection. First line you can start, especially if you have late facilities to do kidney biopsy to send for this. First thing you should start pulse steroid for all any types of acute graft dysfunction, and you rule out pre-renal and post-renal, and now you are thinking either rejection or recurrence primary kidney disease. First thing you should use pulse steroid 500 or 5 milligram per kg for 3 days. And you should start prednisone tapering just 175, 50, then decrease to maybe 20 milligram and 5 milligram daily, and you reach 10 milligram after 50. يبقى 175 50 then 5 milligram down daily until you reach 20, and keep this until you will see what is your first diagnosis, and the slow taper after that to reach again to 5 milligram. Okay, this is number one for treatment if any acute graft dysfunction and you suspect 99% is rejection, any type of rejection, either ABMR or T-cell mediated rejection. What is the main therapy now for ABMR, antibody mediated rejection? Plasmapheresis, you should arrange as soon as possible, 5 cycle, 5 session. And IVIG, it will be given post 5 session, post the 5 session. One till you finish the 5 session, you can give 2 gram per kg. That's it. This is the main 3 types of therapy you will use now. Methylprednisone, plasmapheresis 5 cycle, you should start it now. You can give 3 cycle and you can give 1 or 2 days rest, then you can complete the other 2 cycles. This total 5 cycle. But if your patient highly sensitized with 100% zero CBRA or you have DSA, maybe you can extend it to 10 cycles. IVIG, no way. You should give 2 gram per kg. Don't give 1 gram. 2 gram is the best to cover. As we mentioned already in our talk before, 2 gram to do the work for IVIG, better to give 2 gram per kg. The dimension mainstay of therapy, plasmapheresis and IVIG, according to KDIGO and FDA approved already for that, and the plasmapheresis every other day, but usually we are doing daily for 3 days and you give rest 1 or 2 days according to fibronegel level. Sometimes you do 5 sessions, other center may sometimes you can do 10 sessions. This depends on your sensitization or your patient. If highly sensitized, just go to 10 sessions. IVIG, sometimes you are given after each plasmapheresis 200 milligram per kg, but usually we are giving 2 gram after all plasmapheresis, cumulative dose, 2 gram post plasmapheresis. Either this or this. If you'll do every other day, you can give after each plasmapheresis 200 milligram per kg. If you'll do 3 days consequence plasmapheresis and after that take 1 day rest and you'll go to another 2 sessions, you can give the total dose 2 gram after the 5 session of plasmapheresis. Additional plasmapheresis, IVIG, may be given case by case. This depends on, as I told you, according to the CPRA and sensitization for this patient and the primary cause of this patient, primary kidney disease. They need the benefit from this more plasmapheresis or no. IVIG order, blood transfusion, whatever. DSA before and after treatment, it should be away from IVIG at least maybe 2 days or 3 days because it will give you wrong result. Consider repeat biopsy to assess responses. It's rare to be done, but usually we are doing, but some centers they can do this already. This depends on your facility. ATG or thymoglobulin, if you suspect your patient mainly with like T-cell mediated rejection or refractory to treatment, if you don't have another facility to do any other thing, you can just use ATG 5 to 8 milligram per kg. Most of the center are giving 6 milligram per kg total dose. and you can give 1 to 2 milligram per kg IV according to the patient tolerability, and usually given the first dose small amount, either 50 milligram or 75 milligram, to reduce the cytokine release syndrome allergy after that, and daily adjust the dose. This depends on WBCs and the platelet. And all this discussed already in our induction ITG immunosuppression talk. You can go back to listen for this. And thymoglobulin preferred central line is available, but you can give a peripherally already with close monitoring CBC daily. Other infectious prophylaxis, don't forget to give all prophylaxis management with all heavy immunosuppression again. Don't forget to optimize first the tacrolimus MMF steroid and for higher doses, and prophylaxis medication for BGB pneumonia Septra single strength 800 milligram slash 80 milligram, 400 milligram slash 80 milligram, tablet single strength Septra Monday, Wednesday, Friday, or whatever every other day. Viral Valgan cyclovir, especially if your patient will receive ATG. And fungal, just maybe just nystatin, not fluconazole. GI protection, we can give pantoprazole or ranitidine, and CMV prophylaxis. Don't forget for this, according to your patient CMV status and ATG induction. If refractory, ABMR still resistance, just you can think in to give 1 dose of rituximab or 2 doses. And bortezomib also, some centers tried, these are around 4 doses also. Ocrelizumab also, if you have atypical HUS or suspected, maybe just all this, no evidence trial, but this just recommended. If you have facility to use this, you can use. And dartumumab also can be used. And we'll come to another medication. Antibody mediated rejection must be biopsies, DC, confirmed, destroyed, P plasmapheresis, IVIG is gold standard first line. Optimize your immunosuppression and treat acute cell rejection if present with ATGs. Mixed rejection, will come to this talk. Thymoglobulin for severe or suspicion of mixed rejection or refractory, just you can use 6 milligram per kg total dose. And no FDA approved therapy for ABMR. Data quality considered low to moderate because of small number of underpowered trials, limited use of appropriate controls. Not all studies report clinical endpoint, heterogeneous phenotypes, early, late, acute versus chronic ABMR alone or combined with T-cell mediated rejection. Approach to the patient with ABMR, the best option is prevention. Treatment often less idle because no large good studies already. We spoke about this. Prevention, prevent de novo DNA with good matching, adequate immunosuppression, adherence. Prevention of ABMR in those with preformed DSA with close monitoring and aggressive immunosuppression, and keep your C9 on higher level. Minimize the sensitizing, even avoid unnecessary blood transfusion as possible to prevent this antibody rejection. Identification of anti-HLA antibody during the transplant workup and while on waiting list. Avoidance of non-DSA in organ allocation, virtual cross-matching, also immunosuppression modification. Increase the immunosuppression target. Desensitization if your patient like ABO compatible or whatever. Prevention of antibody-mediated rejection lymphocyte depleting agent by using ATG or thymoglobulin or almituzumab and T52CD TCR receptors. Effect of bezriximab on B cell activation is not stronger than like AT cell mediated rejection. No strong evidence favoring any one agent from clinical trials. But if you are sensitized patient, just go ahead with thymoglobulin ATG. As we discussed before, management, as we mentioned, is support just based on 4 essential mechanisms to treat ABMR. Suppression of T cell response, either by methylprednisone or by ATG or whatever, removal of circulating antibodies, plasmapheresis, inhibition of antibodies also by rituximab or IVIG, suppression of P cells also by rituximab, but no clear evidence for that. High steroid doses, just to summarize, high steroid dose, methylprednisone, decrease inflammation, decrease antibody senses, and decrease the cytokine release and DNA, RNA transcription, and the DNA cycled T cell. We discussed 3 topics, 3 videos about the steroids before. You can go back and you should listen for this steroid for kidney transthymoglobulin, and the mechanism of thymoglobulin we discussed before is clonal depletion for T and P cells. IVIG antibody and anti-complementary, and we discussed clearly in the last talk about immunosuppression, plasma exchange for removal antibodies, and rituximab for resistance AMR, especially for B cell depletion. And this multiple guidelines, Transplantation Society Working Group recommendation, antibody for preformed DC less than 30 days post-transplant. Go ahead with pulse steroid, IVIG, plasma exchange, additional therapy, controversial, but can be considered. And if more than 30 days with chronic active with preformed DC, steroid, IVIG, plasma exchange, consider also rituximab. For de novo dyskinesia with more than 30 days, commonly seen with T-cell mediated rejection. Optimize your baseline immunosuppression. Evidence for plasma exchange, IVIG, rituximab is too low, recommended, but could be considered if you have facility for that. This is different protocols, different strategy, but this depend in your resources and availability. And this just what we mentioned in the previous slide, if less than 30 days or more than 30 days, and you can either with recurrence, preformed or pre-existing DC or de novo DC, different protocols here, whatever you can use according to the availability, but mainly methylprednisone, IVIG, and the plasmapheresis. And for antibody removal, we're using this plasmapheresis, IVIG, immunoadsorption, and IDIS. And for targeting antibody-producing cell, steroids, CD20, rituximab, interleukin-2 proteasome inhibitor, maybe thymoglobulin, and the cellular protection, eculizumab, interleukin-6 blocker. All this available medications is depend on your center and your resources. And we have IVIG here playing in all. And here, suboptimal immunosuppression just will end by this rejection. We should just increase all our maintenance immunosuppression, and you can give pulse steroid just to inhibit the T cell here. Sometimes some centers using thymoglobulin or bilatacept calcineurin inhibitor, all this baseline medication, but some centers use thymoglobulin to inhibit this one to prevent activation of B cells. That can be blocked also by rituximab, plasma cell bortezomib also can proteasome inhibitors, and also plasmapheresis and IVIG playing in this free antibodies in the serum here, either by removal or immunomodulation for these antibodies. And this from up to date, how to deal with antibody-mediated rejection. You can read it, you can take a screenshot, and you can see, but the final point, if less than 1 year, you will go aggressive with all immunosuppression, as we mentioned. Plasmapheresis remove donor-specific antibodies from vascular compartment. You require 1.5 volume removal already, but we have separate talk about plasmapheresis and nephrology in general, and especially in the kidney transplant. Usually we are given around 5 sessions, but if your patient highly sensitized, we'll extend it to a 10 session. And this another indication for plasmapheresis and nephrology. We'll speak about all this, especially recurrent focal segmental, anti-GBM, and atypical HS, and this ABM compatible. We'll speak on all this in a separate talk for plasmapheresis with or without kidney transplant in general nephrology. And as I told you, just 5 sessions, maybe extended to 10 sessions. And intravenous immunoglobulin, we discussed this in our immunosuppression before. I will give 2 grams after my total 5 sessions per kg. And we discussed before, and we spoke before about the mechanism of action IV immunoglobulin. And this all drugs can be used also, rituximab, interleukin-6 inhibitors, proteasome, complement, eculizumab, whatever. This all, if you have facility to use, you can use, because if your patient lost the graft, it will be another sad end already for your patient, or not good for your case. Eculizumab and bortezomib. Some center I attended many centers using bortezomib, but in Canada, really, I don't see anyone using this two agent. And this none of this used in Canada already, but this other syrup is available. But if you have facility, if you have resources, you can use anyone. Better to use, better than none. And this algorithm again, if less than and ABMR less than 30 days, and if yes, you will use all IVIG and plasmapheresis, steroid, and also plus or minus rituximab, plus or minus eculizumab. If this patient not less than 30 days, whatever the according to the if chronic antibody moderation just will maximize the treatment and no active inflammation, you just optimize his immunosuppression and make his tacrolimus at higher level, full dose of MMF if not, and the prednisone also just keep it maybe 5 or 7.5 or 10 milligrams is depending on your patient diabetes or other comorbidities. And this is if your ABMR less than 30 days again. And just this diagram, you can read it just to keep it in your clinic, just to guide you, just to what medication you will start, where you are in these scenarios. And you should discuss with the patient if he's able, because most of our patient paying for this. But here, because most of this medication is free, or in Gulf area also is free, no matter to use any one of this. If get benefit, it's okay. If not, it will come to this slide treatment futility now. انت تعمل العلاج بتاعك انه without جدوى، يعني ما فيش فايده من العلاج بتاعك عموما. انت وصلت لطريق مسدود امتى؟ ما تقعدش تدي، لازم للطريق هيكون فيه نهايه. يعني لما تيجي تشوف العيان بتاعك late acute rejection especially associated chronic non adherence already, what is the benefit of treatment. لو جالك عيان مثلا ما بيتابعش في العياده بقاله 3 شهور او بقاله 6 شهور، وجاي لك بكرياتين 1200 او 1200، او زي ما عندنا مثلا جاي لك بكرياتين 5 مللي جرام او 6 مللي جرام، من البيز لاين بتاعه كان مثلا 0.6 او 1 مللي جرام او وات ايفر. ايه الفايده ان انت تديله انتي ريجكشن حاليا يعني، وتديله اميونو سبريشن وريسك فور انفكشن ومالجنس على الفاضي؟ ولو عملت بيوبسي لقيت اكثر من 70% او 90% سكارنج دلوقتي. ونون انفيزيف ماركر سكارنج، انفكشن، مالجنسي، كوميولاتيف immunosuppression. هنا القصه كلها ان انت لو العين جاي لك نون ادهرنس ليت ريجكشن انكريز سكارنج ان بايوبسي، what is the benefit to give this patient now aggressive rejection medication now immunosuppression. In summary, antibody medication, especially in its chronic form, is an important cause of late allograft loss, even in patients without DC at the transplant. The best strategy to prevent development of de novo DSNE and an ABMR is consideration of better matching maintenance of optimal immunosuppression and ensure ongoing patient adherence. For sensitized recipient, consider kidney per donation, live donor, and highly sensitized registers already deceased donor rather than desensitization. لو عندك highly sensitized patient either kidney per donation أو العيان اللي هم يتحطوا على الديسيزد دونر، احسن ما تقعد تعمل ديسنسيتايزيشن وفي الاخر يجي له اكيوت antibody mediated rejection and graft loss. While treatment may work in acute ABMR, they are much less effective on the chronic form. Once you'll see chronic form, don't treat. Just optimize maybe the maintenance immunosuppression and waiting for arranging for renal replacement therapy either by the next second transplant or another dialysis modality. Result from ongoing randomized controlled trials of several agents with some promise are awaiting. But I think nothing now like amazing medication for treatment of ABMR. This is multiple reference for you if you like to read more about ABMR. طبعا لو في اي سؤال، اي تعليق، اي كومنت، بالله عليكم تعملوا لي كومنتات واي مواضيع انتم محتاجينها بقى تعملوا لنا في الكومنتات واتمنى يا رب يكون في تفاعل وفي سماع وفي فايده واتمنى انه يكون في علم ينتفع به للجميع عموما، وخاصه الاطباء الشباب او المراكز اللي هم طبعا ما فيش حد او ما عندهمش ريسورسز للحياة ديت عموما. اتمنى رب يكون علم ينتفع به ولا تنسونا من الدعاء بالصحة والعافية والستر، ولا تنسوا دايما الصلاة والسلام على حبيبنا محمد صلى الله عليه وسلم. ان شاء الله المحاضرة القادمة هتكون عن الميكسد ريجكشن، ونتكلم عن التي سيل كده بسرعة، تي سيل ميديت ريجكشن ومع الميكسد ريجكشن، وبعد كده نخش على البي كي فيروس والسيمي في، لان الحالات دي بتجيب لنا في العيادات كتير وفي شغل السوق بقى بصراحه. فالحاجات دي كومن بوست ترانسبلانت، وبعد كده نمشوا المواضيع. اي حاجه تيجي في سكتي، اي حاله الواحد يعترض عليها ان شاء الله نحضر لكم الموضوع بتاعها، لان الترانسبلانت ده بحر لن ينتهي وهتشوفوا ان شاء الله، ونحاول نغطي لكم الموضوع باذن الله في المرحله القادمه. انا طبعا سامحوني على المحاضرات اني ما بعملش يعني شو في المحاضرات والكلام ده كله. انا الغرض من الكلام ده كله انا قايل لك البروتوكول، انا قايل لك معلومه، انا قايل لك خبرات الناس هنا، الناس دي اللي تعمل الجايد لاينز وهي اللي عندهم الترانسبلانت بكميات رهيبه. فانا بحاول انقل لك خبره الناس ديت عموما في كل الحالات اللي هتقابلنا، في اي حاله هتقابلنا في البراكتس من الان هتلاقيني جبت الموضوع بتاعها وحطيته لك على طول، بحيث ان انت لما تقابل حاله ازاي تتعامل معاها وإن شاء الله يكون يعني نفع للمسلمين والمرضى عموما يعني. وبالتوفيق للجميع، ولا تنسونا من صالح الدعاء. والسلام عليكم ورحمة الله وبركاته.